So I think it's now my turn, Graham, to ask you to come up and introduce you for your final speaker of this evening's presentations. And you're, I think, going to discuss how specific are structure-function relationships in retina and optic nerve disease.
We now look at structure-function relationships. We'll start with the patient who was referred by an ophthalmologist to establish normal optic nerve function. The patient was mildly myopic, variable fields, touch of colour vision disturbance, but it was really to reassure. And yet when we performed the electrophysiology, the VEP is delayed. The VEP, as we know, is a non-specific response, so we have to do a PATNI-RG to localise the dysfunction. And the PATNI-RG is markedly subnormal bilaterally, so the patient has bilateral macular dysfunction. That then needs a full-field ERG. The rod-specific and bright flash dark adapted ERGs indicate normal rod system function. And then if we look at the cone system, there is marked delay indicative of generalized cone system dysfunction. So the patient has a cone dystrophy phenotype and the imaging is normal. Fundi are normal, autofluorescence imaging is normal, macular OCTs are normal. Now this is a patient who's got bilateral disc pallor, bilateral acuity reduction, diagnosis of heredofamilial optic atrophy, which was questioned because there's no marked ganglion cell loss on the OCT. And then when we look at the electrophysiology, the rod-specific ERG is normal. The red flash under dark adaptation, which should have an early cone component and then a rod component, has no cone component whatsoever, at least markedly reduced. The flicker ERG is generally delayed and subnormal, and the PATNI-RG is undetectable. So this patient indeed has a cone dystrophy with disc pallor. And this is a patient who's got pale discs, another patient with pale discs. And here we see central scotoma. And in this patient, the pattern VEPs are undetectable, the flash VEPs are very abnormal. But the PATNI-RG now shows a normal P50 component, slightly smaller from the left eye, with reduction in the N95 component, indicative of ganglion cell dysfunction. So this is optic nerve and retinal ganglion cell dysfunction. ERGs are normal, and the patient had a variant in OPA1 and has dominantly inherited optic atrophy. So the learning points from these cases are that normal structure does not mean normal function. A VEP delay does not mean optic nerve disease, and disc pallor does not mean optic nerve disease. So what about specificity of imaging? You can have the same disorder with different appearances. All of these patients have variants in the same gene. Some have normal fundi, some have a bullseye type lesion. When we look at the autofluorescence, mostly foveal abnormalities, some with frank hypoautofluorescence, some with a ring of hyperautofluorescence surrounding the fovea, some with speckled hyper and hypoautofluorescence of the fovea, and they're all different, and they all have the same disease. They all have cone dystrophy with supernormal rod ERG and variants in KCNV2. These patients, again, all have variants in the same gene. This patient has normal fundi. This patient is one of Isabel Aldo's, has white dots which hyperautofluoresce on autofluorescence imaging. This patient has hyperpigmented areas which hyperautofluoresce on autofluorescence. Here, there's nummular lesions around the arcades. The only preservation of the autofluorescence is centrally. This patient with a banana type lesion with hypo and hyperautofluorescence. Central schisis, and the classical nummular lesions here are those of enhanced Escond syndrome related to mutation in NR2E3. Now, those two disorders were chosen because they are two of the three disorders in which the ERGs are pathognomonic or diagnostic. You need no information other than the ERG. That's rare, and these are the only three disorders in which I am aware. But you can also get similar appearance from different disorders. So all of these patients have been selected on their central foveal hypoautofluorescence, some large, some small, some with a bullseye type appearance, some with a ring of hyperautofluorescence, some with a ring surrounding. and they all have different disorders. There are some duplications with PRPH2, KCNV2, etc. AIR is autoimmune retinopathy. And these all have similar appearances and yet quite different disorders. What's important also is that most of these disorders are associated with generalized ERG abnormalities and generalized retinal dysfunction, and yet their autofluorescence abnormalities are localized at central retina. Further, you can have the same genetic variant with a different appearance and a different functional phenotype. This was first described by Dick Welleber's group back in 1993, who showed a single family where you could get retinitis pigmentosa, pattern dystrophy, and fundus flavimaculatus in relation to a similar deletion. These 4 patients all have the most common PRPH2 abnormality, the 172 mutation. In this patient, it's a macular dystrophy. In this patient, the phenotype is that of a cone dystrophy, normal rod function. In this patient, it's a macular dystrophy. And in this patient with disease apparently confined to the macula, has very severe generalized cone rod dystrophy. This patient has parafoveal white dots and presents with visual acuity. There's some hyperautofluorescence on autofluorescence imaging, but no old-fashioned OCT abnormality. When we look at the electrophysiology, although one suspected a macular dystrophy, the presence of an abnormal rod-specific ARG confirms that this is not a macular dystrophy. There is generalized rod involvement. The bright flash ERG is slightly electronegative with the B wave smaller than the A wave, so this is generalized inner retinal dysfunction. The flicker ERG is delayed. The single flash cone ERG shows reduction in the B to A ratio, but with overall waveform preservation, unlike the changes in CSMB, where the waveform is dramatically changed. This is simply a B to A ratio reduction. So this is generalized inner retinal dysfunction with macular involvement, and screening showed involvement of RS1. So this patient has X-linked retinoschisis without the classical features. And when Steve Sang was doing a fellowship with Alan Bird and myself back in the late 2000s, we published a series of, I think it was 6 or 7 patients with X-linked schisis, typical ERGs who presented with parafoveal white dots. Typically, of course, patients with schisis have the spoke wheel lesion visible at the fovea, best seen on autofluorescence imaging, and profound scosis on OCT. 50%, of course, will never show peripheral schisis, and the classic spoke wheel lesion will often disappear and be replaced by non-specific macular atrophy as the patient ages. These 3 patients all have molecular confirmed schisis, typical ERGs, and totally atypical imaging, both the autofluorescence and the OCTs. So identification of the functional phenotype or the genotype by structural features alone may be impossible. Now, this is a patient who has a bifid subfoveal cavitation, long-standing visual acuity lost since childhood, and has, I won't go into these in great detail, typical ERGs for KCNV2 or cone distributed supernormal rod ERG. No rod-specific ERG, very high amplitude bright flash dark adductors, and generalized cone dysfunction with macular involvement. But this is another patient who has bifid subfoveal cavitation. Does this patient, and a similar history with poor acuity since childhood. So does this patient have KCNV2 disease? Nothing much to see in the fundi of any specificity. And when we look at the electrophysiology, this patient doesn't have a cone dystrophy. This patient has no detectable cone function whatsoever. We look at the red flash under dark adaptation, cone component is lacking, rod function preserved, and no cone function whatsoever. So this patient phenotypically has achromatopsia, but genetic screening was refused. The 2 main genes for achromatopsia are CNGA3 and CNGB3. This is a patient with CNGB3 mutation and has classical achromatopsia. On electrophysiology, normal rod function, bright flash, and no detectable cone function, including S-cone ERG, so this is complete achromatopsia or rod monochromacy. And yet the abnormality is that of a single foveal cavitation. This is another patient who has a single foveal cavitation, but with a different history. 8-month history of reduced visual acuity, Electrophysiology shows no generalized ERG abnormality, and indeed even the pattern ERGs are normal, suggesting that the abnormality really is very localized. And then when we do a multifocal ERG, we see in the central foveal hexagon very localized dysfunction, with the central response being smaller than its fellows. Back to the history, showed the patient was HIV positive and been indulging in poppers and has Popper's maculopathy. And just to revert back to optic nerve disease, this is a 6-year-old with immune-mediated meningoencephalitis following COVID. The patient was noted by her father only to be able to read when holding things very close. Acuity was reduced. MRI showed no optic nerve involvement that was detectable and was referred to eye. There was nothing much in the anterior chambers, nothing much to see in the retina, but there was a suspicion over whether the left disc was slightly hyperemic. And when we look at the electrophysiology, there's a massive pattern VEP delay. Pattern ERGs to a 15-degree field, not so fantastic. The patient wasn't particularly cooperative, with a large field, beautiful P50, no N95. So this is indeed severe optic nerve disease with ganglion cell involvement, and ERGs, again, with skin electrodes, normal. So, and between January 22 and February 22, possible slight increase in disc pallor, but that's all. So imaging is very powerful. It can reveal unsuspected features, but it's often non-specific, and normal structure does not mean normal function. Electrophysiology reveals function. Occasionally it's diagnostic, but it always reveals the nature and severity of the disease, which may be unsuspected. It can direct mutational screening, and not shown here, can monitor efficacy or safety of treatment. And the most important take-home message is that optimal management needs both structure and function. Thank you very much for your attention.
Thank you so much, Graham, and what a perfect concluding line. So we have something here already in the audience for you. I can't quite see you yet, though. So there's a question. What general suggestions and organizational tips do you have for somebody who's starting up electrophysiology in a tertiary centre?
That question could go on for the whole length of the webinar. Basically, first of all, the person who's going to be doing the interpretation needs to have subspecialty training and needs to familiarize themselves not only with the interpretation, but the ability to perform the tests. Because you're the person who's going to be responsible for training the technicians, so you've got to be able to do the technician's job better than the technician can, so you can teach the technicians. Because they will go, they will come, they may be female and have children and go off somewhere, they may be men and move on. You've got to teach the next technician, so you have to have those skills. You then have to decide what equipment to buy, you have to do normal controls, etc., and the process goes on and on. But most of all, adequate training, subspecialty training, very great attention to detail, because electrophysiology is all about measuring very small signals, and you have to be very precise, very accurate, and skillful, and dedicated.
Thank you, Graham. So I think that sort of comes around to summing up the need for some international education and actual certificated education, I think is important. I have some specific questions, which I wondered if I might just ask. Have you ever seen a recovery of a pattern ERG N95 in any disease? Oh, I'm sorry.
Not convincingly.
Okay. So do you think that's prognostically is very...
Well, when I say that, I mean, yes, you can, but only in the context of recovering P50 when N95 is reduced consequent upon P50. But in terms of reversible ganglion cell dysfunction, no, I don't think so. And yes, it is prognostic. For example, if you think about ethambutol toxicity, ethambutol is used in the treatment of tuberculosis, as you know, and can give you a toxic optic neuropathy. If you stop the treatment while the patient still has a good and normal N95 component, then you've got a pretty good chance, or at least they have a chance of recovering visual acuity. It may take 6 or 7 months, perhaps even longer. But if the N95 has already gone, the chances of getting good recovery following cessation of the ethambutol is slim.
Okay.